So we got a 45-year-old who has had menorrhagia for the past 3 months. On physical exam, there are no remarkable findings. Microscopic appearance of the endometrial biopsy specimen is shown in the figure, and I'll just tell you in the figure, we see endometrial hyperplasia. That's in the figure. Okay. The patient undergoes dilation curettage and the bleeding stops with no further problems. What condition is most likely to produce these findings? So we've got endometrial hyperplasia, which explains the menorrhagia. So we have to explain the presence of the endometrial hyperplasia. Any ideas? What causes endometrial hyperplasia? So first of all, let's start there. Inflammation could cause like reactive change, could cause that. Any other ideas what might cause hyperplasia? Common cause endometrial hyperplasia. So we talked about hormones and how hormone imbalances can cause endometrial hyperplasia. What's the hormone imbalances associated with hyperplasia? Estrogen. Estrogen. This weird funky delay. Estro takes a little get used to. So an increase in estrogen relative to progesterone.
Wow.
Estrogen.
That's
Okay,
crazy.
increase in estrogen. So we have to decide which of these will increase estrogen. So we got ovarian mature cystic teratoma. What do you think of that one? Did that increase estrogen? A teratoma? No. Probably not. I mean, there is a little remote chance, but let's not completely cross that out yet. Chronic endometritis. Does that cause increased estrogen? No, you're right. Okay. Failure of ovulation. So you have, remember, you have the ovarian cycle. Start off with a follicle, ovulates, corpus luteum forms. Yes. Failure of ovulation. So if you don't ovulate, you don't form a corpus luteum, which would, of course, result in a decrease in progesterone. That would mean that the estrogen levels persist. So that's looks like a very good answer. Okay, pregnancy. What do you think? Pregnancy is a hyperestrogenic state, isn't it? We say pregnancy. Pregnancy? It's a hyperestrogenic state, isn't it? It is a hyper. Yeah, I mean, that's kind of, if they're pregnant, why would they be bleeding like that? And there's one other thing. Pregnancy is a hyperestrogenic state, but it doesn't cause endometrial hyperplasia. It causes a secretory type epithelium. Can't do that anymore. Endometrial.
I'm gonna raise it with this finger.
Raise it with my fingers. Okay, so pregnancy wouldn't be the right answer because that would produce a secretory endometrium as opposed to a hyperplastic endometrium. So, no. Use of oral contraceptives. One could make that argument. Some oral contraceptives, the combo pills, are very high in estrogen. However, it's kind of disputed whether it actually causes that or not. So here you have two choices. One is a definite, failure of ovulation, and one's a maybe. So which one are you going to choose? You're going to choose the definite over the. Luke would choose the maybe.
My test history would prove that correct.
Okay. So the right answer here is failure of ovulation. All right, any questions on this one?
Dr. Manning, I know you erased it already, but you said
I should be able to like transmit it to you somehow.
yeah.
That's the-
Secrete something endometrium? What it was?
Secretory,
Okay.
secretory endometrium.
And the answer, did you say that it was a spike in estrogen or just relative to the decreasing?
So you're not making any progesterone.
Mhm.
So estrogen would persist, estrogen would be out of proportion relative to progesterone. Because of the non-ovulation, you don't make a corpus luteum. And since you're not making the corpus luteum, you're not making progesterone. So the estrogen levels would be high relative to progesterone.
Glorified.
A little distracted out here with this thing. Let's see. Okay.
Yeah, that's what I'm saying. I think it was like $1,500. Like, ah, okay.
It's a little bigger. The picture. Okay, there's the picture. So of a 31-year-old woman. 31-year-old woman has dull, constant abdominal pain for 6 months. On physical exam, the only finding is a
Should've done
right
first.
adnexal mass. Okay, what does adnexal mean? Adnexal just means adjacent to the uterus. Adnexal can be referring to fallopian tubes, referring to ovaries. Okay, that's what adnexal means. Something kind of adjacent to the uterus. So we have a right adnexal mass. Could be a tube, could be an ovary. CT scan of the pelvis shows a 7-centimeter circumscribed mass. Is this thing benign or malignant?
That thing's
Malignant.
malignant.
Circumscribed,
Circumscribed.
benign, yeah.
Benign, good.
Yes.
Circumscribed, that's consistent with malignancy. Okay. Okay, 7-centimeter circumscribed mass that involves the right ovary, there it is, right ovary, and contains irregular calcifications. Irregular calcifications, radial densities, are kind of irregular. The right fallopian tube and ovary are surgically excised. The gross appearance of the ovary, which has been opened, is shown in the figure. What is the most likely diagnosis? Let's take a look. And let me move anything. So there is the opened ovary. It's a teratoma. Look, you got hair. It looks like a tooth. Some other tissue here. That's a teratoma. Okay. So we're being asked what the most likely diagnosis is. I think we already made the diagnosis. Mature teratoma would be the right answer. What does it mean when they say mature? Mature teratoma as opposed to an immature teratoma. Yes.
So the unit has multiple different types of tissue in it as opposed to just one.
The definitely refers to the tissue. The tissue in a mature teratoma is well differentiated. Well differentiated. We said this mass was benign or malignant. It was benign, right? So benignancy, bless you. When you have a benign neoplasm, usually the cells comprising a benign neoplasm will consist of cells that are well differentiated. Another way of saying well differentiated is that the cells are mature looking. Mature looking. So this is a mature cystic teratoma, meaning this is a benign teratoma. Not all teratomas are benign. Some teratomas are immature, they're malignant. So when you put this qualifier in front of the word teratoma, mature, you're saying it's a benign teratoma. If you put the word immature teratoma in front of that, well, then that's a malignant teratoma. Okay. Now, we've got all indications that whatever this thing is, it's probably benign. Indeed, mature correlates with benignancy. So that's our best answer. Okay, a mutinous, I think that's supposed to say mucinous. Cystadenoma, is that benign or malignant? That's benign. Cystadenoma, that's benign. Okay, but it would consist of a cystic structure with mucus in it. That's not what we see. We see a cystic mass, but it's filled with all kinds of different tissues. So it's clearly a teratoma. It's not a mucinous cystadenoma. Okay, choriocarcinoma. What's choriocarcinoma? Benign or malignant? Yeah, and so that would not be consistent with the description here. So we can just cross that out. A choriocarcinoma, again, you would not see all kinds of tissues. Choriocarcinoma is composed of what type of tissue? What type of tissue?
I don't think we started studying yet.
You didn't start studying. Wonderful, okay. Choriocarcinoma. That's a placental tissue.
A lot of stuff happening.
Okay.
We're bad students.
You're not bad students.
Aw.
I'll take that. This is your practice.
Yeah,
How many tests do you have this week?
We have 5.
we have one more after this.
One.
One practical after this, yeah.
Yeah, it's gonna be a busy, next busy week.
Yeah.
And what's a dysgerminoma? Dysgerminoma, is that benign or malignant?
Sounds
It's malignant. Yes, it is. They see, you wouldn't know that based on the nomenclature that's used. It actually violates the rules of nomenclature. This germinoma is analogous to what male tumor? Gotta know this. I really messed up. This germinoma is, it's a type of testicular cancer. You know which one? For whatever reason, they ask you this on your boards. The dysgerminoma is analogous to the male seminoma. It's analogous to the seminoma. I don't know why they ask that all the time, but they love asking that question. Okay, that's malignant. We're looking for something benign. And a serous cystadenoma, is that benign or malignant? It's benign. Okay, and what do you think the serous cystadenoma has in it? Serous fluid. And it wouldn't have all these different types of tissues. All those different types of tissues, that implies you got a teratoma. So we don't want that. Okay, any questions on this? There's the image that goes with this. What do you think that is? That's a fibroid uterus. That's what it looks like. Look, you got cervix here, fundus here, ovaries over here, and then you got these masses over here, multiple masses. Let's see what we're being asked. Okay, a healthy 52-year-old woman has a feeling of pelvic heaviness for the past 11 months. There is no history of abnormal bleeding. Her last menstrual period was 8 years ago. She's definitely postmenopausal now. Her physician palpates an enlarged nodular uterus. It's enlarged and it's nodular. This is important descriptors. Nodular. On bimanual pelvic examination. Pap smear shows no abnormalities. Pelvic CT shows scans of multiple solid uterine masses. There is no evidence of necrosis or hemorrhage. A total abdominal hysterectomy is performed. We just saw that specimen. Based on the gross appearance of the mass shown in the figure, what is the most likely diagnosis? So most people thought that was some sort of leiomyoma. Okay. So let's rule out some of these other possibilities just to verify. Could that be metastatic disease? See multiple masses in the uterus. Now, based on the, yeah.
Possibly, but wouldn't you expect other signs of malignancy there? Would you look so well circumscribed and pedunculated?
Good, that's good logic, good logic. You'd expect, based on the mechanics we've talked about before, when you see metastatic disease, usually it present as multiple foci. That's indeed what you see in this uterus. However, it's not uncommon for leiomyomas to be multiple. And also those masses we saw looked pretty well circumscribed. So whatever they are, they're benign, most likely. And that can be kind of a tricky thing. Okay? And so metastases, well, they're usually multiple, yes, but they'd be multiple, but they shouldn't be well circumscribed. They'd be poorly circumscribed. There's one other thing. Is the uterus a common place for metastatic disease? What are some common places for metastatic disease?
Bladder,
Bones.
bladder, I don't know.
Not quite the bladder.
All right.
Name another organ.
Maybe something else.
Prostate, not a common place.
Name another one. We're 2 for 2.
The spine.
We said bone.
Oh, we said bone. All right.
Liver in the lungs, yes. So multiple.
Liver.
Really delimited. We expect things like disease.
Bladder.
Liver.
Yeah, I'm with you.
lung,
I got pee. That's what I thought.
liver, lungs, and bone.
Is that right?
Okay. This is not consistent with metastatic disease. I don't know. Endometriosis. What's endometriosis?
Growth of the uteral tissue on the outside of it.
So it's right. It's ectopic functional endometrial tissue. We call it ectopic functional endometrial. Would it present like masses like that you see? Would there be a nodular enlargement of the uterus? No. There should be no nodular enlargement of the uterus. No nodular enlargement of the uterus. Also, endometrial tissue and the post-menopausal period, that should involute, really. We shouldn't see big nodules, not even implanted in the pelvis. The tissue would involute post-menopausally. So again, this is not what we're seeing for so many reasons. Infiltrating leiomyosarcoma. That's malignant. It's not consistent with what we're seeing. Okay. Malignant. And usually it'll present as a single primary. Single primary. Multiple leiomyomas, you still think it's multiple leiomyomas? Yep, I agree, definitely leiomyomas. These are well circumscribed. It could be multiple. And, well, this woman's postmenopausal. They do tend to shrink postmenopausally. They could calcify. Postmenopause. Still thinking that's the right answer. So, adenomyosis. Tell me about that one. What's adenomyosis? Adenomyosis? Anybody know how it would present? Maybe what it is.
Glandular tissue in the muscular layer of
Bingo.
endometrium.
That's exactly what it is. This is an ingrowth. Growth of non-functional into myometrium. Now, here's an important description. How would that present? Symmetrically, that's the key, or diffusely, either one of those words. This is important. Symmetrical. Or diffuse enlargement. And that is not what we see. Okay, any questions on this one? So we got a 62-year-old obese, nulliparous. What's this mean, nulliparous?
From the null.
All right, no children. Obese, nulliparous woman had an episode of vaginal bleeding. Oh, wait a minute here. She's 62 and she's having bleeding. Does that strike you as odd? Yep. That is one of these big red flags. Okay. Which produce about 5 mLs of blood. Now, I assume when they say blood, it's probably whole blood. On pelvic examination, there appears to be no enlargement. That's an important negative. No enlargement. The cervix appears normal. Pap smear shows cells consistent with adenocarcinoma. Well, yeah, based on what we see over here, this red flag, this would be the first thing we'd have to rule out. Adenocarcinoma. Adenocarcinoma of what?
I'm gonna go bladder again.
Bladder.
Show me bladder.
adenocarcinoma of bladder.
Show me bladder.
That would be more like a transitional cell carcinoma. Bladder. Adenocarcinoma of the cervix, adenocarcinoma of the endometrium, adenocarcinoma of the myometrium. What is it?
Show me lungs.
HPV cause adenocarcinoma of the cervix.
HPV primarily causes squamous cell carcinoma of the cervix. It could cause adenocarcinoma. Adenocarcinoma of the cervix is a little more uncommon, but you're right, it's not impossible. But when we say, when they say this adenocarcinoma, okay, look at this. Cervix appears normal. Adenocarcinoma of what? If it's not the cervix, adenocarcinoma of what? What part? Endometrium. That's it. You're talking about adenocarcinoma of endometrium. And we'd expect that because endometrium is composed of stroma and glands. Stroma and glands. Okay, so it's adenocarcinoma, it's malignant. Which of the following conditions is most likely to have contributed to develop this malignancy? So you got a 62-year-old woman presenting with postmenopausal bleeding. That is really important. Postmenopausal bleeding. Your first thing that you have to rule out in a woman who presents to you with postmenopausal bleeding is an endometrial adenocarcinoma. Okay, so the question is, what is the major risk factor for adenocarcinoma? That's what appears to be what the author is asking us. Well, just think about what are the risk factors for cancer in general? Some of the just generalities. Inflammation certainly can increase the risk for certain types of cancers. Why? Because cells degenerate, they regenerate. Persistent inflammation is a known risk factor. Okay, so do we have that on here? Well, we do have chronic endometritis on here, so that's definitely a possibility. Okay. Which one?
Talking conviction.
You're talking to yourself.
Yeah.
What did yourself say?
It said HPV.
HPV. Tell yourself that's good for cervix. That's good for cervix.
Oh,
That's what you're thinking.
that's what I was, yeah. I was
Tell
like,
yourself to shut up.
Okay.
turn my brain off.
Never told you not to be good. Yeah.
Okay. Well, let's go through these. Endometrial hyperplasia. It's hyperplasia risk factor for cancer.
Yes.
Yeah, definitely certain types of hyperplasia, especially atypical endometrial hyperplasia. This is a risk factor. For endometrial adenosia. That's definitely a possibility. How about use of oral contraceptives?
She's 62, why is she taking more?
62, yeah, I mean, that would be a good argument. Maybe she was taking oral contraceptives before she was before premenopausally, I should say. I don't know if the author was implying that or not. But yeah, I don't think she'd be taking it now. Okay. Anything, can we cross that out?
Yep.
I think so. Yeah, it's not been linked to oral contraceptives. HPV, we've already said this is a risk factor for cervical cancer.
What type of cancer was cervical cancer again?
This would be, type of cervical cancer would be squamous cell carcinoma. Okay, well, so that was out. And how about adenomyosis? Is that a risk factor? Endometrial cancer. It does cause chronic inflammation. Would be a risk factor for endometrial cancer. It causes chronic inflammation of what part of the uterus? Myometrium, not endometrium. Yeah, it causes inflammation, it actually causes reactive changes. Inflammation of myometrium, not endometrium. So that's it. Okay, so now we're down to endometrial hyperplasia versus chronic endometritis. You've got inflammation versus hyperplasia. So now we have to make a decision. So this is the big board exam you're taking. Which one are you going to choose?
Hyperplasia.
Hyperplasia, yeah, that would be much more significant risk factor. Not that chronic endometritis couldn't increase things a little bit. Inflammation usually does, but this is a major known risk factor for endometrial hyperplasia, endometrial adenocarcinoma. So things like this, what caused the endometrial hyperplasia in this case? So look what we got here. First of all, you have obesity. Obesity increases estrogen levels. Why? Because of aromatase. Aromatase. The enzyme aromatase synthesizes estrogen, and the aromatase enzyme is found in adipose tissue. So if she's obese, she must have a lot more aromatase. She's going to be hyperestrogenic just because she's obese. There's something else that's a risk factor here for overproliferation of the endometrium, or perhaps just another risk factor for endometrial adenocarcinoma. She's nulliparous. And if a woman is nulliparous, she must have cycled more than, say, a person who's multiparous. The more cycling, the more growth and atrophy, the more the cells have to replicate, DNA, mistakes. Null parity is actually a risk factor for a lot of different types of cancers in women. Endometrial adenocarcinoma, ovarian cancer, especially ovarian cancer. Okay, so we've got a couple of things going on here, but the major risk factor here is the atypical endometrial hyperplasia, and that was probably a direct result of her obesity. What made it worse was her parity. At no time did her uterus get a break from cycling, being stimulated with a lot of estrogen. Okay, yes.
Can you just say what chronic endometritis would lead to?
Chronic endometritis could be relatively asymptomatic. Could be asymptomatic. There could be like discharge. And in fact, it might contribute to a decrease in fertility. Histologically, this is characterized by the presence of no specific cell. The endometrium is a part of the uterus which is open to the environment. So there's going to be some
Lymphocytes.
There's going to be some physiologic inflammation. Lymphocytes, you're going to see that normally.
I'm using bladder. Bladder. Say bladder.
Bladder cells. Yeah.
Bladder cells.
You're going to see some transitional epithelium there. Now, how about plasma cells? Plasma cells.
Second.
That was your second case. Good for you.
After bladder.
All right, any questions on this one? Key things: obesity, remember, hyperestrogenic state. Major risk factor for endometrial cancer would be any kind of hyperplasia, particularly if it's an atypical hyperplasia, which means the cells not only proliferating, but they're starting to look funny. Atypical endometrial hyperplasia. Okay, anything on this?
So if you had hyperplasia of the myometrium, then you could get the whatever the last answer is. Adenomyosis or whatever.
Adenomyosis. Adenomyosis is a condition that's seems to not have many known risk factors. It
Mhm.
seems that some people it happens and some people it doesn't. There could be some correlation with, say, endometritis. Something drives it to proliferate within the myometrium.
Mhm.
However, the exact risk factors are not as well defined.
Okay.
Can't really. Okay. Any questions? I think, is this the last one we have?
Maybe there's 2 more or 1 more.
Okay.
I can't count.
All right, well, why don't we take a break and then we'll pick up.
Sounds good.
Let's go back.
What are we looking at here? So we see
Crowded, right?
okay, so why don't we label the parts here?
Oh,
Yeah, why don't you slow down?
that's on my.
Okay, what's out here? This is, all right, this is vaginal wall. Out here, and what is this? That's ectocervix.
The ectocervix.
And how about what's running down here? There is the basement membrane.
Like, so you guys need to start studying it.
Okay.
Okay, so we got the basement membrane down here. And of course, down here, we'll just call this subepithelial tissues. Subepithelial tissues, right down in here. Okay, so let's take a look at this. Anything wrong with this?
They look crowded.
Crowded.
Yeah, that's really good observation.
Yeah,
of mine.
it's pretty crowded.
Yeah.
Overpopulated.
Some dysplasia.
Clearly overpopulated. That indicates a lack of proliferative control.
We should see some mitotic figures.
Some mitotic figures. Wow, let's look in there.
Right
Yeah.
there. You don't see that dot?
Oh, next to the neutrophils, right?
See?
There's
Don't
one.
forget that one and that one.
Huh.
Yeah, you gotta stand farther
There's
back.
something else. I can't even see it. Okay, you got some mitotic figures according to you. Okay, mitotic figures. So, what would you call this lesion? Apparently, they're calling it a lesion. So there must be something. This is definitely overproliferation. Now, you see how crowded it is. Would you call it hyperplasia, or would you go one more and call it dysplasia?
I go dysplasia.
Dysplasia. Okay, yeah, that's good. Dysplasia. So we have
Discussing with
dysplasia.
my colleagues, we decided on dysplasia.
Yeah.
So we have a dysplastic ectocervix. Would you go even farther? Would you say this is squamous cell carcinoma?
If we're in the cervix, yes.
Has it penetrated? Did you you see the ectocervix very crowded, like you said, dysplastic? Has it penetrated the basement membrane?
No.
No. So would you call it cancer?
No.
No. Would not call that cancer. Not squamous cell carcinoma. It's dysplastic. It might develop into squamous cell carcinoma eventually, but that's not where we're at right now. So we would call this some sort of dysplasia. How would you grade this dysplasia?
CIN 3.
CIN3, and I'd go right there with you, it's CIN. Now, definitely CIN3, would you go one more and upgrade it to CIS?
Sure.
Yeah.
Yeah, you would.
Yeah.
That is CIN3, and specifically it's CIS. CIS stands for carcinoma in situ. It's the worst kind of dysplasia you can have. Look, it's full thickness, crowded throughout the entire ectocervix. You've got all kinds of pleomorphic forms. There's no architectural organization, or at least very little of it I could see. It looks like you're crowded through and through. That is definitely CIN3. Specifically, it's carcinoma. Okay, any questions on this?
Wait, what's the answer?
We haven't even gotten to the question.
Oh. Ah,
Okay, they just call it a lesion here. All right, so again, young woman, she's 33. And they're calling this a lesion. We've identified this lesion as carcinoma in situ, which is a type of dysplasia. By definition, benign. Have to stay that way for long. Okay, so what are we being asked? Which of the following factors is likely to have contributed to the development of cervical dysplasia? What causes most cervical dysplasias? 90% or more. HPV. So, yeah, HPV. And by this time, you know the oncogenic serotypes. Okay. So, look through here and see, well, what would increase their exposure to HPV? There's definitely a correlation with the earlier the age of first intercourse, the more likely the woman's going to have a greater exposure to different serotypes of HPV, specific oncogenic serotypes. And so there has been a correlation between developing cervical dysplasia and the first age, age of first intercourse. Okay? Okay, presumably this causes a greater exposure. Greater exposure to HPV. Diethylstilbestrol. Okay, what does that do, if anything? It's a carcinogen, and do you know what specific type of cancer it causes? Which one? Squamous cell carcinoma. That's a good guess, but in this case, it causes a different type of carcinoma. It's actually an adenocarcinoma. We call it. We actually don't call it an adenocarcinoma, even though it is. Okay. It's caused by this artificial hormone when a fetus is a female fetus is exposed in utero to this artificial hormone. Vaginal clear cell cancer, which is the type of adenocarcinoma. And it seems about 1 in 1,000 female fetuses exposed in utero to this hormone will develop vaginal clear cell cancer. And this is a non-steroidal estrogen. Now, we don't use it in any circumstance where we're going to expose a female fetus in utero to it, but we do use this hormone to treat prostate cancer. Prostate cancers tend to be responsive to androgens, and so if we use an estrogen to antagonize the androgens physiologically, we tend to get a reduction in growth of the prostate cancer. Prostate cancers love androgens, and if you try to antagonize the effects of the androgens with estrogens, the growth of the cancer, prostate cancer decreases. Okay, not the answer. Recurrent Candida infections. It certainly can cause, Candida certainly causes a vaginitis. What's the risk factor usually for a Candida vaginitis? Candida albicans vaginitis.
Just
Immunocompromised certainly could cause a nasty Candida albicans vaginitis. So immunostatus is a more common one.
you looking for like yeast infection or what do you?
What causes a yeast infection? Antibiotics is a big one. Yeah, antibiotics. Okay. So recurrent Candida albicans infections, usually immunostatus. If it's recurrent, it just might be a problem with the immune status. Antibiotics would be the most common thing amongst women that can cause a Candida albicans vaginitis. Sometimes a Candida albicans vaginitis will develop if a woman is constantly exposed to warm, moist environments. But these are the big ones. Okay, but it's not associated with cancer. It can cause, if anything, atrophy of the vaginal mucosa. And that means that the vaginal mucosa could tear during intercourse. It gets very thin. Okay, multiple pregnancies. Not a risk factor. In fact, multiple pregnancies actually reduce the risk for certain types of cancer, particularly ovarian cancer. Postmenopausal estrogen therapy, again, not a risk factor. Not a risk factor for cervical cancer. It does increase the risk for breast cancer and possibly other cancers. Okay. Any questions on this one? Okay. We do have an image for this. Okay, let's first take a look at the images. Let's just read the history first. 46-year-old perimenopausal woman. So she's not menopausal, she's getting there. Her pituitary ovarian axis starting to fail. Has had pelvic discomfort for 5 months. Physical exam, uterus appears slightly enlarged. There are no adnexal masses. Cervix and vagina appear normal. Total abdominal hysterectomy is performed. Okay, shown in the figure. Which of the following is most likely? Which of the following is most likely prevented by the hysterectomy? So, what kind of complications of this lesion did we avoid? Okay, so let's take a look. So this is a resected uterus. Okay, and does anyone know how we're oriented here? It's a
It
uterus.
looks like we're looking at lateral view.
Hey, what's this part right down here? That's the cervix. Six. Okay. And those are the ovaries. Okay. We got the endocervical canal right there. And what is this?
well circumscribed
A very well circumscribed mass. Is that benign or malignant?
benign.
Probably benign. Probably benign mass. And this one?
It's the bladder.
That's a smaller one.
It's a smaller mass, same thing though. And it's a smaller mass, it's benign, and it's still well circumscribed. Okay. Got a white cut surface. Any guesses what that is? Those masses, multiple masses? Benign. White cut surface. Those look like fibroids, yeah. Probably fibroids, leiomyomas. What are fibroids composed of? We got a biopsy. We have to look at the histology. What are they composed of? What's that? Stroma. There'll be some stroma in it, but the main component would be what? Lyo meaning smooth. That's smooth muscle. So it's kind of benign, proliferating smooth muscle. Okay, that's what we see. Let's have a look at the biopsy. Right? Any guesses what that is?
Looks perfect.
Looks perfect. Well, believe it or not, that's smooth muscle. It's just kind of all oriented different. Now, these are smooth muscle cells. I doubt very seriously whether you put this in front of someone who's not a pathologist that would actually recognize that this is actually well differentiated smooth muscle because it's so poorly oriented. That's smooth muscle cell right there. And I will just tell you, that is a well differentiated population of smooth muscle cells. Is that consistent with a leiomyoma? Yes, it is. Well differentiated, they're mature. That's consistent with benignancy. Okay, that is a correlate of benignancy. So, okay, let's again go back to the original question. So they're really not asking us to make the diagnosis. They assume we know the diagnosis. They're asking us to identify the complication we avoided by performing a hysterectomy. So 46, hysterectomy is performed. Okay. Most likely prevented. What did we prevent by giving this woman a hysterectomy? Cancer. One of those. Malignant transformation. Yeah. So what we're saying is that a leiomyoma can transform into a sarcoma. Okay. Now, the question is, has any leiomyoma ever been documented to undergo malignant degenerative surgeries? We don't know. I can tell you the answer to that is no. If it does happen, it's never been documented. And so it seems that the malignant counterpart, which would be a leiomyosarcoma, seems to develop on its own, does not evolve from some sort of leiomyoma. It's something we just had to know. So if this woman has a fibroid uterus, by performing a hysterectomy, we probably didn't prevent a malignant transformation since that would not have occurred before. But that would have been a good guess, very good guess, because certain benign neoplasms, can undergo malignant degenerative changes. adenomatous polyps of the bowel. Remember that one? Those are implicated in bowel cancer. So that was a good guess. Anything else? Might guess.
I don't see how iron deficiency can be an answer.
You don't see how.
Yeah.
I might actually agree with you there. I mean, she's perimenopausal. Usually leiomyomas, though, do present with menorrhagia.
Mhm.
They can cause heavy bleeding. So let's not leave that out. Let's try to get the answer then by excluding everything else. Endometriosis. Perform a hysterectomy to avoid endometriosis. Endometriosis is ectopic endometrial tissue.
Still gross.
The hysterectomy would not prevent endometriosis if the endometriosis is there. In a 46-year-old, I don't think we would prevent any endometriosis. Although again, I think one could argue that one. Someone could have a valid argument. Right, so topic endometrial tissue. Which cycles? And one could say that you could prevent an endometriosis, but presumably the author is referring specifically to lesions that we've seen, which are leiomyomas. Leiomyomas are not related to endometriosis. So on that basis, I would cross this out. Osteoporosis.
I don't see how that could be an answer either.
Yeah, I don't see that, how that could be an answer. You can't, in fact, you could say that you've actually accelerated osteoporosis by giving a woman a hysterectomy, total abdominal hysterectomy. Okay, this might be accelerated. I don't see that being the right answer. Invasive mole, you know, again, you could make an argument and say, oh, well, you know, invasive mole, that's kind of a pregnancy gone wrong. And so you remove the uterus, you can't get pregnant, so maybe it's not related to a leiomyoma, though. Not related to leiomyoma. Preeclampsia, what is preeclampsia? Preeclampsia. Do you know what eclampsia is? It's also known as clamp, yes. It's also known as the toxemia of pregnancy. Toxemia of pregnancy. Okay. Eclampsia is a condition where a woman becomes hypertensive and starts developing seizures. At the end of pregnancy, it's thought to be related to a placenta that is ischemic. It's detached partly from the uterus wall, and women develop hypertension and they can have seizures. Preeclampsia is basically all that minus the seizures. And again, you could argue, well, you took the uterus out, you can't get pregnant now. But again, that's not related to the fibroid. So I don't think that's the way the author's thinking. So this would be hypertension and okay. Iron deficiency, I think that's the only one we can link it to. If she has a fibroid, one of the symptoms is menorrhagia. Okay, they don't even tell us that she has menorrhagia. So this is I can't tell you how unfair a question is. I think that's what the author is asking.
Well, let's not rule anything out yet, Jordan.
I would not give you something this slick.
Yeah, this is super slick.
Any questions on this? It was a good review of something. Other than that, it has no value.
There's no way a time deficiency.
Yes, it is. That's quick. Why is it
Okay, that's it.
happening? Okay.
I guess we can't really practically get started with the review. Okay, so again, review, Wednesday at 6, I'll set up a link. I will record it. Remember, exam 4, GU endocrine. Don't neglect the endocrine. It will be a large component. Anything on this?
It's because it's asking what it would prevent by
Yes.
removing the uterus. You're getting rid of any chance of bleeding from menopause.
So
bleeding
you want some warm-up
from,
questions? Okay.
any future hyperplasia or dysplasia.
That's what those things cause. that
Well,
lion
because if she was bleeding for any
That's what
reason.
lion-
you could
Okay, if
be
I
iron
told
deficient.
you a
It's a shitty question.
67-year-old woman presents to you complaining of bleeding,
Iron deficiency anemia.
iron deficiency anemia is going to be your first concern. Which kind of cancer? Which kind of cancer?
You know,
You know,
The
I
kind.
know. What's your first suspicion? 67-year-old woman presents to you with
With-
bleeding.
I'm concerned
Uterine
about.
cancer, what kind of uterine cancer? Endometrial. Endometrial. That's your first concern. That's the red flag. Okay? And see? What are some of the risk factors for endometrial cancer?
Diabetes.
Diabetes. Obesity is a good one.
Diabetes. Okay.
Heavy bleeding related to what? Endometrial, oh, yes. Endometrial, heavy bleeding is associated with endometrial hyperplasia. Hyperplasia is good. Okay. Let's see what else we have here. You have a 40-year-old woman complaining of heavy bleeding, severe dysmenorrhea. You do a exam, conduct an exam, and you discover the adnexia are normal, but the uterus is symmetrically enlarged. What's your first guess?
Who's that one that started with the A?
The one that started with the, that's right, adenomyosis.
Yes,
You're
that
right.
thing.
Adenomyosis.
Yeah, that's all right.
Who's that?
Okay. let's- You have a 15-year-old girl complaining of menorrhagia,
Used to it.
and you do your physical exam, nothing identifiably wrong or with the uterus. Uterus seems fine. There are no lesions that you can identify. Why do you think that woman is developing heavy bleeding at the age of 15?
HPV.
HPV wouldn't cause bleeding. It causes dysplasias, cancers, warts.
Why is she bleeding?
Why is she bleeding so heavy? Well, she's starting menstruation. Why so heavy?
Does she have a clotting issue?
You know, that's actually a possibility. That's actually a good possibility.
See?
She's got some sort of bleeding diathesis. And the most common would be like a deficiency in von Willebrand's defect. Actually, that's a really Not the one I was thinking of.
Just the day over here.
How about when we talked about
Oh, yes, yes. Oh, the ones we talked.
it? She probably have a history of epistaxis as well.
At this.
Nosebleeds. Easy bruising,
Yes, the
nosebleeding.
rhinitis, yes.
But aside from all that, how about the fact that she's perimenarcheal? Early, she's just beginning cycle. Heavy bleeding, what usually causes heavy? Well, first of all, what would be your diagnosis before we get to the cause? This actually has a name. Heavy bleeding, perimenarcheal. Nothing wrong with the uterus, nothing physically wrong anywhere that you can find. By definition, what would be called this? DUB. What's DUB stand for?
Dysfunctional uterine bleeding.
Dysfunctional uterine bleeding, and dysfunctional uterine bleeding is caused by what? Excess estrogen relative to progesterone. So why is she bleeding so heavily? She's not ovulating, and so her ovarian pituitary axis is probably still immature, and it's probably temporary. Okay,
What were the keywords you said for that? You said
dysfunctional
something.
uterine bleeding.
Yeah.
There, by the definition of dysfunctional uterine bleeding is heavy bleeding in absence of any organic lesion of the uterus, meaning there's nothing physical.
And you said something with like E
with
as a. No. Oh, it was like, oh, something.
excess estrogen relative to progesterone. It could be an absolute excess or relative excess. All right, here's another one then. You have a 21-year-old man presenting to you with Cushingoid features.
Of course, yeah.
Emotionally labile, buffalo hump, a moon face.
Buffalo woman is calling.
You do some tests and you discover that the person has hypercortisolism, but low levels of ACTH.
Cancer.
What are the possible causes?
Cancer on the adrenal gland.
Could be cancer of the adrenal gland. Could be some sort of ACTH is low. What are the two possibilities? Something wrong with the adrenal gland. What's the other? The ACTH levels are low.
The pituitary is fine.
Oh, okay, yeah.
It's not, wouldn't be pituitary Cushing syndrome. It could be adrenal gland Cushing syndrome and one other possible.
Sounds like an interesting
Is
question.
there anything else? Where else can it cover that? Is it just the kidneys?
Sometimes you get cancers that produce
Oh, okay, not like.
paraneoplastic.
Yes.
Paraneoplastic could cause Cushing syndrome. Well, maybe I misinformed. Cancer can cause Cushing syndrome, but it usually causes Cushing syndrome by elaborate ACTH. Anything outside any cancer outside the adrenal gland generally produces Cushingoid changes by producing too much ACTH as opposed to too much cortisol. Maybe it could, there's one other possibility, it could be exogenous cortisol. Exogenous cortisol. So possibly adrenal Cushing syndrome or exogenous or iatrogenic Cushing syndrome. Those are the two possible. Someone define Sheehan syndrome for me. Sheehan.
Endocrine,
You
dude.
got- you didn't
This is
start
endocrine
the
stuff.
Oh, this is endocrine?
This is endocrine.
This is
I'm like searching.
He's
for
just talking
this
about
stuff.
Cushing's.
Oh,
so-
yeah, that makes sense.
How do you spell it?
Sheehan syndrome.
Oh, shit.
I found it.
Anterior
Severe blood loss.
pituitary glands are just, so it's just pan-hypopituitarism, what's it called?
Lack of blood flow to the front part of the pituitary gland.
Lack of blood flow, and that usually occurs under which circumstance?
Low blood pressure.
Low blood pressure.
That's a good Google search you got there.
And the low blood pressure is caused by what? Childbirth. Yeah, hemorrhaging during childbirth. There are a couple of components there. Sheehan syndrome.
Oh, no,
First
it's
of all,
much.
the pituitary gland becomes hyperplastic during pregnancy, but there's no increase in capillary density or blood flow to the pituitary gland. So it becomes marginally ischemic. You add to that hemorrhaging during delivery, hypotensive event results in a critical hypoperfusion of the anterior pituitary gland, resulting in degenerative changes, and the anterior pituitary gland destroyed. That results in panhypopituitarism, meaning there are no hormones elaborated from the anterior pituitary gland, and that's called Sheehan syndrome. That's a endocrine question. Which of the following best describes Sheehan syndrome? Okay. Anything else? All right.
Nope.
Same one.
Well,
We'll see you on Wednesday, 6 p.m.
Oh, buddy.